Good morning and good evening, everyone. My name is Purba Chatterjee, and I'm the Associate Director for Global Health Equity at the Institute for Global Health Sciences, as well as the Department of OBGYN Bixby Center. And it is really my immense pleasure to introduce my friend, colleague, and my DrPH cohort mate, Dr. Silvana Larrea-Schiavon. And Dr. Silvana is, just to tell you a little bit about her, she's a public health researcher whose work focuses on migrant and refugee health, including sexual and reproductive health and access to care in the context of vulnerability. And she's actually, maybe I'll let her tell you, she was, as of, I guess, yesterday, part of UCSF, but has just recently accepted a new role. And I'll let her tell you all about it in just a minute. And Dr. Silvana holds a DrPH from the University of California, Berkeley, and a master's in public health, and a specialty in preventive medicine from Mexico's National Institute of Public Health, as well as a medical degree from the National Autonomous University of Mexico. And her doctoral research examined access to sexual reproductive health services among undocumented migrant women transiting through Mexico from a health systems perspective. And with that, I would also like to introduce Dr. Triveni DeFries. Dr. DeFries is an associate professor in the Department of Medicine and the director of UCSF Health and Human Rights Initiative. So after Dr. Silvana does her talk, then Dr. DeFries will lead a sort of facilitated discussion. And Dr. Silvana's title of her talk today is Beyond Crisis Framing, Rethinking Migration Policy and Health System Responses in Mexico. And just a reminder, these talks are part of UCSF Institute for Global Health Sciences Global Partner Spotlight Series. And really the goal of these talks is to bring together voices from diverse settings and backgrounds to share insights, challenges, and innovations that shape the future of global health. So with that, I would like to hand it over to Dr. Silvana, and I hope that please join me in warmly welcoming her today. Thank you. Over to you, Dr. Silvana.
Thank you, Purba, and thank you, Triveni and Andrea, for the invitation to give this talk. As Purba said, I'm still a UCSF employee today, but after tomorrow, I'll be moving back to Mexico City to work with Doctors Without Borders as the head of research for the country office. I'll start my new position on Monday, and I'm very excited, but also very, very grateful to have been able to be part of the UCSF community. And I'll start my talk. I'm going to share my screen. I think you can see it there. And I'm just going to close this up. And so the talk for today, the idea of it, I think it has been in my head for several years. I've been working in Mexico in topics of migration and access to healthcare services for 10 years as of now. But it really sort of solidified with my doctoral research that I did in some interviews in 2023 in Ciudad Juárez, in the border with El Paso in Mexico, and also in Mexico City. And the focus of the interviews of the research, as Purba mentioned, was access to sexual and reproductive health services. But this idea of crisis and emergency and like short-term responses kept coming up from these interviews and talks that we have with different stakeholders. And so I'm going to present a little bit of this idea that was formed through these interviews. And so the central argument for the talk is that really Mexico's policy and health response to migration has largely been shaped by this idea that it's a crisis and it's a temporary phenomenon. But what we've been seeing through the last 15 years is that the migration flows in the region have become like really structurally embedded in the country, and we need a different policy approach. And this quote from one of the interviewees that we interviewed in Mexico, I think like really summarize this central argument. This interview shares, no, I think we need to position the migration issue very carefully, because there has always been this talk about the migration emergency, right? But this emergency has been going on for years. I mean, in 2018, when the first caravan arrived, it was called an emergency, and then the Haiti emergency, and then the Venezuela emergency, and now we are in a constant emergency, right? But this is no longer an emergency. This is a reality. And so to develop like this central argument, I'll first talk a little bit about how the migration reality in Mexico has changed, especially in the last 2-3 years, how this has an impact on the health outcomes of migrant communities in Mexico, and how these health outcomes are also compounded by how Mexico has been framing the migration issue in the country, and how it has shaped the policies, the implementation of these policies, and also the perception of migrant communities, not only by policymakers, but also by healthcare professionals and the Mexican population communities, and what would a different framing would look like. So starting with how the migration reality has changed in the country, historically, Mexico has been considered like a country of origin of immigration, especially to the United States. And this was true for many, many years. But starting more or less in 2010, we saw like a change in these migration flows to something that we call transit migration, where Mexico became like this country of passage, of transit for many, many people whose goal was to reach the US, but needed to cross the Mexican territory to be able to cross the border and arrive to the US. However, in the last couple of years, due to different factors that I'll be sharing in a little bit, this sort of transit that really people were staying in Mexico for 15 days, a month, and the maximum was 3 months, started to become a situation of protracted transit where people are staying longer and longer months and years in Mexico. Also a country of destination because people have decided to ask for asylum in Mexico instead of the US, and of return due to either the voluntary return or deportation of Mexican nationals as well from the US. And so some of the policies that have created this change or that have reshaped this mobility in Mexico, enacted by the US, these are some of the most important. It's not like an extensive review of all of the policies, but I think that are one of the most important that we have seen in the last few years. It started with this policy that was called Migrant Protection Protocols, or MPPs, or the Remain in Mexico policy that was enacted in 2019. And the idea of these protocols was that asylum seekers that crossed to the US and asked for asylum in US territory were then sent back to Mexico to wait for their US court dates in Mexican territory. And there are some studies that say that approximately 68,000 individuals were returned to Mexico under this program. And this happened until 2021. At the same time, during the COVID-19 pandemic, Title 42 was also enacted. And this Title 42 said that, or used public health grounds to rapidly expel migrants who also crossed to the US under this idea that it was for protecting the public health of the US. And if you remember, most minors were exempt from this Title 42, which led to family separation. And again, some estimates says that over 2.5 million expulsions were recorded between fiscal years 2021 and 2023. And then more recently, we had this digital tool that was called CBP One app that started in 2023 until January of 2025. And the idea of this app, it was that it was a digital tool where people who were in countries that were not in the US, and this was mainly Mexico, but other countries such as Nicaragua also, could apply for asylum via this app. And then once they received like approval for their US court date, they could travel to the US and wait for their US like court date inside the US, and they could like apply for a work permit as well during that period. And this looks like better compared to Title 42 and the MPPs, but there were like some troubling factors associated to this app as well. For example, even if they could apply for work permit, applying for a work permit was very, very expensive. So many people didn't have the money to be able to apply for this work permit. And also, while staying in Mexico and applying through this app, you needed like continuous access to the internet and Wi-Fi. You needed a cell phone. The language options were restricted, and it was sort of a black box. Nobody knew exactly why people were being selected. The idea was that you entered like your data each day on this app, and if you didn't receive confirmation of your US court date that day that you entered your data, then you needed to reapply and reapply each day, the same app, the same data, etc., that you had to enter. And some people like got their US court dates 2 weeks after their first application, but there were some people that were waiting for 8 months, a year, and they hadn't received their US court dates. And again, it was like a black box. Nobody knows what were the criteria for selecting the cases. We don't know if it was like sort of a Russian roulette, and this created a lot of uncertainty and had an important, significant mental health toll for people who were applying for asylum through this app. And more recently, as you all know, there's been a complete like destruction of the asylum processes in the US, a closure of the border, the deportations that we've seen, and also some other containment strategies. And so the impact that all of these policies and more have had, again, in the mobility dynamics in Mexico is that even though less people are arriving in Mexico, we have that in 2024, more or less 900,000 people arrived in Mexico versus 227,000 in 2025. We've seen an increase in refugee applications in Mexico and also an increase in asylum applications in 2025 compared to 2024. And a survey conducted by the International Organizations for Migration in 2025 among more than 1,500 migrants found that 80% had been in Mexico for 6 or more months. Remember that before it was between 15 days and a maximum of 3 months. 51% saw Mexico as their final destination, which is double the 2024 figure. And I think the most important and the one that I want you to keep in mind throughout the conversation is that 73% of the people surveyed had no document regularizing their migration status, even if they had been in Mexico for prolonged periods. So why this matters for health, no? And I think the critical thing is not that they are in Mexico. It's not that they are spending prolonged times in Mexico. It's not only that. I think mainly, again, is that most of them have an irregular migration status, even if they are spending all of this like prolonged time in the country. And having an irregular status has implications in terms of, for example, housing, not being able to access formal housing markets. Before, when the times in Mexico were not as prolonged as we have now, the main like housing arrangements that people use were migrant shelters. But these migrant shelters were created like for very short periods of time. They were critical actors, like they provided access to food, to water, to a safe space where they could sleep. They created like these connections with international agencies and non-governmental organizations to provide services inside their facilities so that that people could have access to legal services, psychological services, health services. But again, they were created for very short periods of time. There's no privacy in most of these shelters. There are really like there are a lot of rules around for safety, so around exiting and entering the shelter. So it's difficult for people to find a job because they can't like leave the shelters at certain points or re-enter if they get late to the shelter from work. But there's no like other real option, no, for them. It also creates barrier for formal employment, additional barriers for health services, and lack of access to justice systems. No, and again, it's not that the justice system in Mexico is perfect, and if you have documents, then you'll have access to it. But just being in this irregular status creates these additional barriers. And some data that we have, and the data that I'll be showing you has many limitations, mainly that it's old. We haven't had a survey to understand the health needs in a long time. I know some of them are there are some research that it's been done by the National Institute of Public Health and other research institutions as of late, but they haven't yet published the results. And the other is that most of these surveys, again, are cross-sectional. They use convenient sample, etc. But this is the data that we have, so it's the one that I'm going to show. This first set of data comes from a survey that's done both in the north and the southern border of Mexico. This was an analysis from this survey that from 2015 to 2019. And what they found, for example, is that 29% of the people who they surveyed had experienced extreme temperatures, almost 80% no access to food or water during their stay in Mexico. 14% were abandoned by smugglers at some time of the transit route that you can see it here in the map on the left. 8% had got lost in transit, and then 5% were at some point at risk of drowning. Another survey that was done more recently in 2022 among 668 women that were staying in different shelters at in different states in Mexico show that most of the health needs are related again to the context of migration. So respiratory diseases, gastrointestinal diseases, accidents and lesions. 15% reported experiencing sexual violence since their first arrival to Mexico. We have dehydration and skin lesions. And on the photo on the left, this is a photo that I took in 2018 when we were in Veracruz, doing some also interviews and surveys. And this is the place where people were staying at this moment. If you see it, it was not even a shelter. It was like an abandoned structure where people found some like roof to get out of the sun for a little bit. Women and children were here and were not allowed to leave this space by like the leader of this particular group. And so what the health systems in this particular city were doing is to go to this place to offer at least some type of primary healthcare services for the women, the children, and the men that were there. And finally, we did an analysis of a survey conducted in 2021 in Ciudad Juárez with 252 undocumented migrant women. And this is one of the only analyses, and again, with all the limitations that it has, that looked at if the time spent in Mexico was associated in any way with the prevalence of different sexual and reproductive health needs. And what we found is that women who have stayed in Mexico for more than 30 days reported experiencing the different sexual and reproductive health needs in more frequency than women that had been in Mexico for less than 15 days. And some of these are more obvious. If you are in a place for more than 30 days, then it's more probable that you'll have some sort of menstrual health or management needs. But some of them, like sexual violence or experiencing some reproductive tract infection-related symptoms, could indicate that something is happening. Not staying in Mexico for longer doesn't mean that you'll be less exposed to some conditions that could have an impact in your health. And so in summary, again, the evidence base is not great. It has a lot of limitation and it's still growing. But I think that there's a pattern that we also heard in the interviews, that the longer people remain stranded in precarious conditions with an irregular migration status, the greater the accumulation and urgency of health needs. And this is just an example of another interview that we did with a local decision maker. And he shared, it's good that many of the migrants are sheltered, but if you saw how the streets are full of migrants, of women with their small children, some of them very little, still breastfeeding, these women become a loot, right? They are harassed by men driving their cars. In other words, in many ways, some, not all, but some are forced into sex work for money. And some others, men and women, are being used by the mafias to store drugs, to sell, in short, for many things, right? And I included this segment of the interview because I think it speaks to these other social determinants of health, especially housing, lack of access to formal employment, and how in the end it impacts the health outcomes of this population. And this is also compounded, especially the fact that they are staying for so long with an irregular migration status, by how Mexico has seen or has understood this migration dynamic in the country. And it's important because how we understand or problematize something has an impact. It activates different institutional logics and responses that have different outcomes. And so I divided like this framing into two. One is this crisis framing And this crisis framing implies that there's a tipping point, no? A change, a rapid change, high volume, there's a limited time frame. And this crisis framing activates emergency frameworks, no? That prioritize like reaction, short-term like strategies over planning. It activates extraordinary and reactive resources. Usually humanitarian actors are in the lead because they have the knowledge and the experience on how to activate these programs very quickly. You have short-term responses that are directed towards urgent needs. And some, not always, but sometimes it's associated to these narratives of national security. I think we've heard a lot of this in the US recently. No, it's a migration crisis, and then we have a crisis of insecurity and a crisis of resources, etc. And on the other hand, we have this understanding of migration as something that has happened for many years as a structural phenomenon. And the idea of thinking of this way is that then it activates like planned and institutionalized responses. And maybe if needed differentiated, it doesn't mean that you always need like a differentiated policy. But you do need infrastructure and sustained resource planning. Another way of thinking of this, also pathways to regularization. And it's accompanied in many times with a reduction of stigmatization because, again, there's planned resources. There's not this thinking that migrant communities are coming to the country to take all the resources that are actually for us, etc. And during the interviews, this thinking of how migration is temporary or a crisis and how it impacts the institutional responses came up. One federal decision maker, she does not agree with this, but she was explaining why we have the type of programs and policies that we have in Mexico. And she was sharing, no, I think much of the government response has been emergent, precisely these waves of visibility, no, talking about the caravans. Migration is always thought of as something temporary. So if it's something temporary, then why would I invest in it? Why would I create a specialized or differentiated public policy if that person is just going to pass through? And another different federal decision maker was sharing the only coordinating body responding to everything that was happening in terms of migration in Mexico that exists is the emergency committee. And then she goes to share that if the emergency committee is the one responding, then again, we're thinking of this as an emergency, as a crisis. And at the end, she says, no, it's not an emergency, it is here to stay. So it has this thinking again of migration as a crisis, as something temporary, has had an impact on how policymakers are thinking of migration and then what type of policies are being put forward. But the question that I have is, and it's up to discussion, but is migration in Mexico actually a crisis? No? Could we define this phenomenon as a crisis? And I think that if we use the definition of crisis as this abrupt change and extraordinary volume, we can discuss that it's not really a crisis. No, in terms of abrupt change, this type of migration dynamics, this in-transit irregular migration has been happening and increasing steadily since 2010. And so this is not an abrupt change. It's something that we've been seeing for the last 15 years. And in terms of volume, we know this, again, are estimates, but between 2019 and 2025, more or less 16 million people transited through Mexico and an estimated 6.3 million stayed, which represents more or less 4.7% of Mexico's total population. And this is very close to the 3.7% that the International Organization of Migration just published in their World Migration Report in 2026. And if you read this report, they use this percentage again and again and again to say that what we are seeing in terms of forced displacement in general in the world is not a crisis. No, it's something, again, that we've seen for many years. And in terms of volume, it's not as great as a volume as sometimes we see media sharing or policymakers sharing in their discourses. And I just, in this section, I wanted to show, again, using some examples from the interview, how this crisis framing has shaped the policies that we have in Mexico, how it has created implementation gaps, and also how it has shaped the perception of healthcare workers and the Mexican community at large. And what I'll be sharing in the next few slides is sort of this linear, I don't know how to call it, but sort of events. So as we'll see, Mexico has like codify the right to health in different policies and laws and programs. However, due to this view of migration as temporary, as a crisis, the type of programs and policies, especially directed towards access to healthcare services, have been short term, which has led to a weak operationalization of these policies at the local level, creating implementation gaps, and then local levels having to rely on the work of different non-governmental organizations, community-based organizations, international agencies to be able to cover some of these gaps. But the problem is that there are some municipalities, some cities that have more support from these NGOs, international agencies, and also more support from the local levels. And there are other municipalities where there's almost no support, creating this unequal access to healthcare services, which again impacts negatively the health outcomes. And these health outcomes are also being impacted, as we saw in previous slide, by this dynamic where there's a protected transit with an irregular migration status, which again is being reinforced by this crisis framing, and especially, as we'll see in a little bit, with not having these pathways, no, to even temporary regularization for many of the people in these communities. So it is important to recognize that over a decade, Mexico has made like significant progress in terms of policies to extend health rights to migrants. However, there's a lot of implementation gaps, and also the coverage has been repeatedly disrupted by institutional changes, especially since the government changed from the PAN-PRI to the Morena party since 2019. And so starting in 2008, we see that irregular migration was decriminalized in the population law in Mexico. In 2011, there was like this great change in like Mexican laws in terms of following human rights international laws. And one of these changes was to codify the right to healthcare for everyone, regardless of migration status, in the Constitution, in the General Health Law, in the Migration Law, and there was also the creation of the Refugee Protection Law, the creation of the Refugee Protection Law. And then in 2014, so 3 years later, after this happened, there was this first attempt to operationalize the healthcare access via the Seguro Popular. The Seguro Popular was this sort of public health insurer. And what they did is that they created this policy where migrants, regardless again of immigration status, could access the Seguro Popular or could enroll in the Seguro Popular for up to 90 days. And if you see again, is this idea, even if since 2010 we have already seen this increase in transit migration, we have this idea that migration is temporary, it's only 90 days, and so that's all they need to access healthcare. We don't need to actually do this as a right, but only like for 90 days, that's enough. The Seguro Popular kept going, and this policy kept going until 2019, where it was disbanded for different reasons, some of them having to do with like in perceptions of inefficiency and corruption of this health insurance. And the INSABI was implemented, and this created another implementation gap because the first like operational rules of INSABI said that to access healthcare services, people had to present a number that's called CURP that could be sort of a simile to the social security number that you have in the US. In Mexico, it's called CURP. And the people who are in an irregular status don't have access to a CURP. You have to be in the process of asylum or have some type of regular status to be able to have this CURP. And so this created a lot of problems with accessing healthcare services because when they arrive to the hospitals or the clinics, they immediately ask for this number, no? Which people didn't have. And in 2020, they also created this healthcare program for migrant people. This was like we were very excited for this healthcare program. I think it demonstrated like a political will of increasing access, of improving how the Mexican government, especially the Ministry of Health, was responding to the different health needs and barriers to care for the migrant communities in Mexico. However, what happened is that the idea for this healthcare program, it was to first publish like a general version of this program, not very specific. And then through the years and in collaboration with different stakeholders, it would get like transformed into something that's more like operationalized. But the pandemic came, and so the priorities changed, and this program was never like improved or touched again. It's still there in the internet, but if you read it, it's very general. It doesn't give a lot of information on how to actually like again improve access, diminish barriers, what is the role of the Ministry of Health. And so in the end, it just ended up being like this policy that or this program that didn't had like an impact on the actual access to care at the local levels. And in 2023, we had another change, another big institutional change from INSABI to IMSS Bienestar. This is the current sort of system that we have in Mexico. And in their operational rules that just, I think, got published last year, at the end of last year, they do mention in-transit migrants as one of the populations of interest, but the focus or the solution that they include to increase access is focused only on increasing availability of interpreters. There's no other like potential change that we could make to increase access, and they still say that people need the CURP to access services, even if there's been like publications or people from Bienestar saying that you don't need the CURP, but in the policy, if you read the operational rules, they're still in there. And this creates like a lot of anxiety and confusion in clinics and hospitals at the local level of knowing what to do. And finally, very recently, you may have heard, but there's this proposal for a universal healthcare system. It was introduced a few months ago, and we still don't know how this will like work for, again, migrant communities that have an irregular status in Mexico. And if we see at large, like the National Development Plan and other plans that have been put forward by the Sheinbaum administration, most of the policies that talk about migrant communities focus on Mexican nationals that have been returning voluntarily or deported from the US, and there's not as much focus on other types of migration flows and dynamics in the country, such as this protected transit dynamic that we are seeing. And if you see here again, there's been this advancement in terms of where we were to where we are now. There's still many areas of opportunity, but there is an advancement. But we have also seen on the other side from the like ministry, how would you call it here? Like La Secretaría de Gobierno would be like the Ministry of the Interior, I think, has had another approach to migration. For example, in 2014, the same year that the Seguro Popular, this policy from the Seguro Popular was implemented, Peña Nieto also implemented this Programa Frontera Sur, which the idea was to focus surveillance, and like they say that it was to dismantle trafficking networks. But what happened is that they limit the use of this train that was known as La Bestia and forced people to go to other routes that were much more isolated and that passed through what in Mexico is known as red zones, where criminal groups are very present, and this created a lot of other problems, no, in terms of safety and security and kidnappings. And then in 2019 till present, there's also been deployments of the National Guard, mainly following US pressure to stop migration from the southern border of Mexico. And this National Guard has been acting as a containment force in both borders. And again, it's this idea from the US that we need to stop migration in Mexico. They don't want people to cross to the US, and Mexico has to do their job to contain the migration flows in the country. And finally, this de facto safe third country that again has been happening more or less since 2019. And it's important to say that Mexico has never ever approved being formally a safe third country, but in reality it has happened in different ways. For example, accepting the migration protection protocols or the Title 42. And in the bottom, we have part of an interview segment from a medical coordinator of an international NGO that worked in several parts of Mexico. And she was sharing what they were seeing in the southern border in Chiapas, in Tapachula. And she says, no, they, as the government, have not really created a management strategy for this situation, but rather a strategy of attrition or militarization or repression. Now they are using a strategy of dilution. I mean, people arrive, they put them on buses and transport them, and they kind of abandon them along the way. And what was or is happening is that when a caravan arrives to the south of Mexico, there's the National Guard, they have these buses, and they take people to different places in Mexico so that there's not this concentration of people in those ports of entry in the southern border, and then they just abandon them. And in some of these places, there's no access to COMAR, which would be the Refugee National Commission of Mexico. And so they have no access to process of asylum seekings, there's less access to resources, etc. And so that's what she's sharing in this segment of the interview. And this idea, again, of migration as a crisis, of migration as something temporary, it not only shapes the type of policies that are being implemented, but also how clinicians are thinking of their work, of their job, of their everyday work in clinics and hospitals. One part is related to the implementation gaps that I was sharing a little bit earlier. Besides some of these policies being short-term and temporary, there's also no implementation guidelines on how to really realize the right to healthcare at the local level. For example, these federal decision makers is sharing, what does it mean to be sensitive to the migrant condition? How would you apply that? What does that mean for a physician that's receiving a person from Haiti that has an irregular status? What would that mean in terms of actually implementing that idea of being sensitive to somebody's migration status? We don't have those guidelines for physicians and nurses and social workers that are working at the local level. Another thing that came up during the interviews is this idea of resource competition. One of the physicians in the hospital was sharing, and she says, as a doctor, I have had to deal with migrant people coming and demanding things from me when many times my health services doesn't even give medicines to me. And she says, so what it is like is that the health personnel have this thing of I unprotect one to care for another. I unprotect those from my city, the Tarahumaras, to care for another who comes from somewhere else. So this idea that if there's not enough resources, they, as physicians being paid by the Mexican government, should prioritize the care and the resources for the Mexican population and not for somebody that's coming from outside. And finally, this idea of, I call it the servingness narrative that comes from an article that was published by Seth Holmes from Berkeley and other colleagues. And it's this idea that on the one side, there's people that deserve care more than others. But on the other, there's also this idea that I think also more of charity. You're here in Mexico, we're giving you everything. And so you don't have the right to complain if the quality of care was not good enough, or if the facilities are not good enough. You have to be happy with whatever you have. And this idea goes against the fact that Mexico has signed and ratified several international treaties and has an obligation to comply with what they have signed. It's not charity, it's not something that we do because we are, the country has like good people. It's something that the country should be doing because it's their obligation. And finally, it has also impacted the perceptions about migrant communities by the Mexican population. And so we have a segment of an interview from a director of a migrant shelter in Ciudad Juarez, where she shares that she has heard more and more people from Ciudad Juarez saying, why are they migrants here, no, if they don't want to be in Mexico? And they are getting help from here, and the supplies and resources are going to that population instead of us. And a federal decision maker also shared that in the south of Mexico, they've received complaints from the communities and the health services because there's been this disagreement between the community and the health services, where the community is saying, okay, you can, like, your services are for us, and you can give some services to migrant communities, but in this case, for example, just give 4 medical appointments each day, right? You have had an investment from the municipality, and your responsibility is to serve the people from this municipality first. And so this has created also tensions at the community level. And we see this reflected in other ways. For example, in Chile, Chile was like really a faro, like a lighthouse in terms of migration and health policies, at least in Latin America. However, in recent years, again, there's been this crisis narrative, how they've been overcome by all of the people that are arriving, how the resources are not enough, how the crime has increased. And Cast, which now is the new president, when he was doing his presidential campaign, used this a lot to say, look what the previous government has done, look at all the people that have arrived, it's a crisis, we don't have enough resources. And this created like a lot of people in Chile were like in accordance to what he was saying. And in some surveys that were conducted in Mexico, some of these ideas, again, of how migration is negative for the country comes up. For example, in 2023, in a survey conducted by ACNUR, 52% of people surveyed from Mexico thought that the presence of refugee and migrant populations increased the crime rate in my city, or that 3 out of every 4 surveyed Mexicans considered that the migrant caravans contained people who committed crimes, etc. So again, this came up in the interviews, but we've seen it like projected into other surveys and news that we have been hearing. So after this, what is like a different way that we could look at it and that we could change like some of these views and narratives? And to me, the main thing is that there is this reinforcing loop where we name something a crisis for many, many years. The type of policies that we have are reactive, are short-term, which creates that the needs are not being met, which again creates this perception that it's a crisis. And an example, it's, for example, housing. No, if people don't have any other housing options, they can't stay any longer in shelters. They are going into these informal settlements in several cities of Mexico that don't have access to bathrooms, to water, to food. And this creates an idea for the people in Mexico, for the politicians, that this is a crisis, because you've seen this presence of irregular settlements that they were not there before. These settlements are increasing in size, but you don't do anything in terms of housing policy. You keep doing reactive policies, like we'll just give donations like water and food, which is important, of course, but it's not the only thing that we need to really break this cycle and start finding other ways, additional ways that go more into like the structural determinants of what's happening. And some ideas, these are not the only ones that there might be, but these are some ideas that I've been thinking and discussing also with other colleagues in Mexico. Is, for example, at the policy level, the first thing is we need to think how to transition again from this emergency response in, for example, disaster management or humanitarian crisis, where there really is a crisis, you have these different phases of the response. No, you have preparedness, you have the acute emergency response, then you have a sort of a recovery response, and then you get into the long-term response. And I think in Mexico, we have no preparedness or management strategy, and we have not been able to transfer from this acute response phase to a recovery and a long-term response. We need to ensure access to rights, regardless of migration status, to housing, to formal employment, to education, to justice, to healthcare. And we need to involve the local levels, the people who are really on the ground responding to all of these needs, because there might be some barriers that at the federal level they are not seeing, that the local level knows that they exist. And so the policies also need to respond to these barriers to be able to be implemented. And the fourth thing is we need to integrate to these responses the experiences and knowledge of the migrant people who are the experts on what's happening, on what barriers they are facing, and some of the solutions that we could be implementing. So how do we create these spaces of political, how do we say it, like political sharing, a commitment with migrant communities as well. At the institutional level, we need to develop guidelines on how to implement these big policy levels, like at the constitution level or at the general health law level, to the local clinics and hospitals. We need to establish dedicated funding. There's no dedicated funding right now. Again, it's coming from this emergency funding that is usually thought of when there's a natural disaster, or compensation mechanisms for clinics and hospitals that have high demand. Provide continuous supervision and support for healthcare personnel, not only one-time training. Right now, what it's being done is give this one-time training to healthcare personnel in clinics and hospitals. But in Mexico, most of these personnel are residents who are not sleeping for 36 hours straight, who already have a lot of trainings and have to study for their exams and have a lot of pressure. And there's also a lot of institutional violence in the hospitals on them. And so it's not only this one-time training, but also how do we support them continuously during their work, so that if they have questions, if they don't know how to act, there's someone who can they go to and discuss and see what can be done. And the fourth part is the need to incorporate public health training in undergraduate healthcare education. In Mexico, I know here it's different, but in Mexico, you go to med school as an undergrad. You start med school like at 18 or 19 years old. And at least in my experience in the university where I did my medical training, there was no information about structural determinants of health. There was no public health training. And so to me, medical students go out into the world not having this very, very important training and thinking again that health is something individual and that we can blame like the individuals for not taking the medicine, for not going to the doctor, etc. There's no other way of thinking about this health disease parallel. In terms of data and evaluation, another problem that we have that you might have guessed throughout the presentation is that we really don't have systematic data about migrant populations in Mexico. Most of the data about migration and health comes from surveys and other types of studies that are conducted by research institutions, but the health system is not collecting this type of data. And I know there's worries about how to protect this data that's so sensitive. But I think that there might be like a medium between what type of data we can collect, how we can protect it to better inform the policies that we have. Because right now we have no idea. We have like an idea because we see it in the ground, but not really data on how many people are using health services, what type of health services they are using, what type of resources clinics have versus those that are being used, etc. And finally, I think we also need to work on the social response. This is not only happening in Mexico, it's happening in all of the world. It's like really stigmatization and discrimination of migrant communities in different countries. And so I think we also need to work on this, for example, through investing in public communication that accurately portrays the realities of migration, countering misinformation, making data and policy decisions and resource allocation more transparent, at least in Mexico, so that people don't think that there's a lack of resources. And then how can we create these spaces where migrant communities, people from Mexico, healthcare workers can come together and also learn from each other? And so overall, I know it's late, but I think the four main points is, again, that migration in Mexico is a sustained regional phenomenon. It's not a crisis. It's not something that just happened. This crisis framing has influenced how governments respond to the migration phenomenon in Mexico, and it has created implementation gaps, and that the goal must be to reduce vulnerability and ensure rights, not just these short-term responses. And so to finalize, my takeaway is that the challenge is not migration itself, it's how countries and societies respond to it. And in the case of Mexico, we need policies, programs, and strategies that reduce vulnerability and guarantee access to rights and services, because the emergency response, the short-term response that we've seen is been insufficient really for achieving these goals. And thank you for the invitation. Thank you for listening. This is my personal email if some of you want to remain in contact. And I'll stop sharing so we can go to the questions and reflections.
Great. Thank you so much, Silvana. I think we have about 8 minutes. So, Triveni, do you have any questions, or should we just open it up to the audience and see if? Okay.
Happy to start us off, and folks can think of questions. I see one in the chat already. Thank you so much for this talk, Silvana. I think it's so timely, and it just shows the interconnection of those of us who are currently seated in the United States and feeling the impacts of immigration policy in the United States. And you've really illustrated how it has ripple effects, and we are interconnected in the way that those policies impact Mexico and other countries. I wanted to add a reflection just to get your thoughts. In my work, I have had the privilege of being on the ground in Mexico and Central America, working with many migrants. And I think something that really has struck me is the incredible diversity of migrants that are currently in Mexico that you're talking about. And I think many people think of mostly this population as Latin American or Central American, or even internally displaced Mexican folks, but truly the diversity is incredible. We have a lot of global health folks in the audience, and many of the people from the regions that you're working in Africa, Middle East, Asia, are truly the population that you're discussing today, who are in transit, but also now living in Mexico. And I just wanted to ask, like, how do we understand that diversity? How is research capturing or not capturing that? And how are the services adapting to the incredible linguistic and cultural diversity of migrants in Mexico?
That's a very good question. And yeah, I didn't mention it, but there's more than 100 countries represented in the migration flows. The main one, it's still from Latin America and Central America, but more and more we're seeing from Haiti, for example, and from other countries in the world. I think how health services are adapting, again, it depends on where you are and the will of that particular city or local municipality. But what I've seen in Ciudad Juarez, for example, is that they have hired people from the community in the case of Haiti, because there were no Creole interpreters or French interpreters. And so they hired some of the people for the clinics and the hospitals so that they could act as interpreters. And there were some worries there because the community was not as big as it is now. And so there's some concerns in terms of confidentiality, using interpreters that might know you, etc. But that was the way they were trying to to adapt. And in terms of policy, as I shared, the IMSPI and STAR mentioned that what they will be focusing on, at least in paper, is that they'll try to create more interpretation services in the different hospitals and clinics as a reflection of the only language that's spoken is not longer just Spanish, but many, many others. And as research, I think there's a big gap because usually we do the surveys in Spanish or English, but there are some, I think there are some surveys also with people from IT, but all the other populations are much less represented in the different research studies that have been done.
Thank you. Lucia in the chat has a question that certainly echoed a question that I wanted to pose as well, which is how can we play a role as researchers or global health practitioners or clinicians focused in the United States? How is there a role for stronger binational collaboration?
Yeah, that's a really good question. Thank you, Lucia. And I agree that the US is not the only to blame, but I also think that it is part of the changes and things that are happening. Um, and there are some like really interesting like binational collaborations already happening. There's I always forget the whole name, but there is this binational Mexico-US health initiative, I think it's called, led by Gudelia Rangel. And I think it's one of the UCs. I don't know if it's UC San Diego or UCLA, but that has been happening for many, many years. There's this interesting collaboration between UCSF and El Colegio de la Frontera Norte with the idea, and they are doing this promotora model where promotoras are the ones who are reaching out to the migrant communities in several states in the north of Mexico. And UCSF is leading sort of the creation of the curricular and the educational side. So I think there's a lot of opportunities of collaboration. I think right now it's a little harder with all of these directives from the federal government in the US, or at least I've heard that it's harder to collaborate with other countries. But hopefully in a couple of years we can continue and strengthen those collaborations.
Great. Thank you so much. Are there any other questions? I wanted to highlight that one of the many pieces of work that Silvana has been connected to at UCSF is a partnership and evaluation of the Soccer Without Borders program. And we are in the World Cup phase of our lives. And we have another one of these partner spotlights upcoming. And so I just put it in the chat. We have the Health and Human Rights Initiative along with Soccer Without Borders giving a talk about collaboration and building refugee youth leadership. So please check that out. It was sent out on the IGHS channels. Purba, I'll hand it to you to close out.
Yeah, thank you, Silvana and Triveni, for this really engaging talk and discussion. And Silvana, wish you all the best in your new role, and hope to stay in touch. And that's it. Thank you all for joining. I'm going to turn my camera on for a minute. All right. Thank you, Silvana.
Bye. Thank you.
Bye. Bye.